So today, I really wanted to narrow my talk where we could do a deep dive into the contemporary management as well as potential prevention of artificial urinary sphincter erosion. So these are my disclosures. So today I want to talk about causes of erosion, risk factors, how erosions present, as well as ways that we manage erosion, and are there ways that we can prevent erosion? So as we all know here, the AUS is considered the standard therapy for moderate to severe stress incontinence in male patients. It is a fantastic quality of life operation, but as we talked about earlier, it's not without its potential risks. So because of its mechanical and compressive nature, well, we're all well aware of the risk of mechanical failure, infection, and erosion. So erosion is what we want to talk about today. And as we all know, and what has been described, that there are certain risk factors that can predict whether a patient will progress towards erosion. In my mind, the most predictive risk for future AUS erosion is prior AUS erosion as well as prior AUS surgery. Also, any surgery on the urethra, whether it be a urethroplasty or a urethral stent, also is a risk factor. And I think plus minus radiation. I think that there's still some debate out there whether radiation can lead to erosion as an inevitable consequence, but I think that the general consensus is that we have to treat radiated patients very conservatively. And lastly, does even a penile implant lead to erosion? And that's something we can talk about as well later in the case. So what are the causes? So causes are divided into two different types of camps. There's iatrogenic, that's caused by us, that's caused by providers, or those are caused by nurses on the floor, and there's also idiopathic. So our goal is how can we minimize both, and in some ways, it really is going to be very important for patients and their family members to advocate for themselves. And there was a study at the AUA this year that investigated, is there a better way of identifying patients with an AUS beyond just doing a med-alert bracelet? And also, there's idiopathic erosions. So idiopathic erosions are the ones that are created by slow ischemia over time. Could be related to a very small indolent infection, but it's typically because of a compressive ischemia phenomenon that occurs over months to years. So how an AUS erosion will present is very much dependent on the cause. So if a patient has an acute erosion event, typically caused by a catheter, cystoscopy, patients will present with signs and symptoms of an infection, and they'll have perineal swelling, they'll have scrotal swelling, and that's due to because of urinary extravasation into the spaces. But how about those indolent erosions? And we see this in our practice, and they'll present with very subtle signs. Worsening incontinence, maybe some discomfort, or maybe nothing. We all see this in our practices. Patient shows up, they're lost to follow-up, and they show up 10 years later, and they've got a pump sticking out of their scrotal sac. So invariably, you perform cystoscopy on them, and they have a complete circumferential erosion of their cuff. Well, as Dr. Flynn was talking about earlier, patients become more frail, less dexterous, and perhaps they just left the AUS on completely on for years, and they're just never using it. Well, what can happen with constant compression is you're going to get an erosion. So we looked at 98 patients that we had in our cohort that had erosion, and we saw that up to 44% actually only had incontinence as well as just an unanticipated just erosion seen on cystoscopy. 56% had scrotal swelling, but there's a significant portion of patients that just show up with very subtle signs of an erosion. So once you identify an erosion, well, first you have to perform cystoscopy. You have to confirm that erosion was actually taking place. So usually a patient will come in and saying, "Doc, I can't pee, I'm in a lot of pain, scrotal swelling, you gotta get a catheter in." So we will see that patient in clinic. Fortunately, in our practice, we have not only a cystoscope, but we also have a digital ureteroscope, and we are able to at least get at least the flexible ureteroscope all the way into the patient's bladder, bypassing the cuff site, put a wire, and then we place a council tip catheter over the wire. We typically like to place a 14 or a 16 French catheter. We don't get greedy with anything bigger. Once we have the urine drained, we can take the patient to the operating room. That's going to be up to OR availability. But once you get drainage of the bladder, usually patients can be cooled off with antibiotics. If for those really small indolent erosions, there's no rush for that. You can usually wait about a week for that if they have no scrotal swelling or any sort of other systemic signs. But for the patient that needs to be taken, they've got significant scrotal swelling, obviously admit, take them to the operating room. Once you bring them to the operating room, then you want to remove the device, but now you've got some options of how you're going to be repairing the urethra. We keep the catheter in place for 4 weeks, but in our practice, we sometimes have patients say, "Doc, I don't mind the catheter. I don't want to be incontinent while I'm waiting for that next AUS." And so there's some variability there. I always tell someone, well, you have to kind of pick your poison here. If I take out this catheter, you're going to be fluorally incontinent. If you have a catheter, you actually have to deal with a catheter. So it's about 50-50 which patient, what they choose. So where erosions occur can also dictate how you repair the urethra. So Dr. Mori put out a really nice heat map of where erosions occur in his practice. And this is very consistent with what we see here at USC. Most erosions are occurring ventrally and lateral. Very rare for it to occur dorsally unless you've got that big monster circumferential erosion. So what do you do with the urethra? There's several options. You can just place a Foley catheter. If it's a small ventral laceration, you can perform a primary repair. If it's a small posterior repair, if it's a dorsal laceration, and it's very small, I'm not going to go fishing for that actual hole. I'm just going to place a catheter. If you try to mobilize the urethra and rotate it, you actually may cause more damage than you're actually achieving anything. And lastly, if there's a circumferential erosion, we try and mobilize both directions, and we try and perform a direct anastomosis to really eliminate that dead space. If you leave a circumferential erosion wide open, then that's when you really develop issues such as stricturing and fistula. For all patients, we do interpose healthy tissue over the repair in all cases. We're just trying to do a multi-layer closure to prevent any communication to the perineum. So does the strategy matter? I think there's still some debate as to whether there is a right or wrong strategy, but something should be done. So the Cleveland Clinic group looked at their group of 75 patients. They did a comparative analysis between Foley catheter alone, abbreviated urethroplasty, as well as primary anastomotic urethroplasty. And they found that when you actually look at each type of repair, what predicted a stricture was actually the severity of erosion. It actually wasn't the repair. They also suggested that small erosions could be managed with a simple urethroplasty or a Foley catheter alone. And this was corroborated by a multi-center retrospective analysis, group of 78. They did the exact same comparative analysis between a Foley catheter alone, single capsule repair, as well as urethroplasty. And they found that stricture rates did not vary by repair type, but again, strictures were more common in total erosions compared to partial erosions. So in contrast, Dr. Mori looked at his patients. They saw that if you compare in situ urethroplasty, which is diagrammed below, which just shows an approximation of a ventral laceration versus Foley catheter alone, in patients that had a urethroplasty, they resulted in lower rates of stricture versus Foley catheter alone. And it also predicted a higher likelihood of undergoing successful reimplantation. This was very interesting. This was just published last year or 2 years ago from a European group. They actually looked at a prospective review of their strategy of doing absolutely no repair, no urethroplasty, no mobilization, no urethroplasty. They didn't really document the severity of erosion, which is one of the biggest issues with the study, but they just placed a suprapubic tube and a catheter. And they left the catheter in there for 3 weeks, and then they followed patients, and after 18.7 months, only 2 patients developed a stricture. So what does this all mean? Well, we looked at our USC approach. We follow a very standardized treatment algorithm when we see a patient with an AUS erosion. We just want to establish continuity. We want to get drainage of the bladder with a catheter. I firmly believe that it's far more helpful to place a catheter before you remove this device than actually placing a catheter after you remove the device. After you've removed the cuff, then all the tissues become very abnormal. So place your catheter beforehand. We stopped placing a perineal drain. We used to place it a drain, but we found that the outputs were just markedly low. There was no purpose for it. And then we see patients 4 weeks later. We perform a voiding cystourethrogram or cystoscopy. And then the patient has to decide whether they want a catheter or not. We now wait 4 months minimum before placing a new AUS device. But as Dr. Flynn talked about and as Lanaine will talk about, well, at some point, We have to know when to stop, and maybe we should be offering urethral ligation, diversion, or even adjustable balloons in some patients that are already cursed. So what are our results? So we looked at 98 patients, and we found that this was a very, very high-risk patient population, multiple prior erosions, radiation, urethroplasties, double cuffs, urolooms, all of this. And we looked at our outcomes. We found that 9 patients developed a de novo stricture, so that's 9.2%. Now, of note, 18 had a stricture, but 9 of those patients came in with a prior stricture. 7 of those patients were managed endoscopically, 2 required urethroplasty. And then we also had 6 patients develop a fistula. Fistula is by far the worst complication you can get after this. 3 patients required a fistulectomy, adjacent tissue transfers flaps to get that corrected, and 3 patients actually just resolved by itself with prolonged Foley catheterization. Minimum catheterization for those fistula patients was 3.5 months. But we always give patients the benefit of the doubt. We keep trying to place AUSs, and that's just historically what we've done. So, we have a 3 strikes and you're out rule, but I think we could probably argue that even after 2 erosions, that third one is likely going to erode at some point too. So what are our outcomes? So yes, we were able to place AUSs in this very high risk, multiple erosion patient population, but after after latest follow-up, only 48% had a functioning device. 14% progressed to diversion, 28% with a catheter, a suprapubic catheter. So definitely, once you go on that erosion train, it's very difficult to get off of that erosion train. So what do you do with the IPP? So I think that there's some question as in a patient that also has a penile implant that presents with an AUS erosion, do you have to take out the penile implant? No, we don't. I think that we looked at it, in that group of 98, 28 had a penile prosthesis. Not one had a crossover infection to the penile implant. And also, you have to consider, well, we left a catheter in these patients for a minimum of 3 to 4 weeks. Well, did that cause secondary erosion distally with the penile implant? No, not one of those patients. So Aaron Lentz is also looking at this at Duke. Now, the biggest disclaimer is that we place most of our penile implants infrapubically. Lentz does it penoscrotally. Morey thought that there was perhaps a risk of erosion with a penoscrotal penile implant. So I think that before we can make a broad generalization that a penile implant is not impacted by having a prolonged catheter or erosion, we have to look at the 2 different approaches. So when do we attempt a replacement? Minimum 4 months. If it's just one erosion, you don't necessarily have to do a transcorporal technique, but after you start going through multiple prior erosions, absolutely a transcorporal technique will be necessary there. So takeaways, in a contemporary and high-risk cohort of patients presenting with AUS cuff erosion, stricture rates are still low, fistula is very low, but once those develop, you're kind of really hosed your patient. So the goal is really to prevent that from happening, and really the biggest goal is actually to prevent erosion in general. So what do the guidelines say about erosion? So they simply say, if a patient comes in with an erosion, remove the device, place a catheter for a minimum of 3 weeks, and then consider replacing this device minimum 3 to 6 months afterwards. And also, they talk about the type of repair. It's what we talked about. You can do whatever you feel most comfortable doing. Foley catheter alone may be appropriate. In situ urethroplasty may be okay. But in my mind, if you're seeing a patient with an erosion, you have to take into account the severity of the erosion, where it's located, to really decide on what is that best type of repair. So can we prevent erosion? All this talk about how bad erosion leads to bad erosion outcomes. Well, maybe we should be preventing erosion. So how we approach the high-risk patient is through careful patient selection, and we consider urinary diversion in that AUS cripple. Maybe that third AUS device, that third erosion is just not going to work. So maybe we should just move towards other options. We're big fans of using all pressure regulating balloons, but we love using the 5160, which we'll talk about. And we also do the delayed activation. High-risk patient, we're not going to activate them at 6 weeks. We wait minimum 10 to 12 weeks. And we recently studied to see whether that actually impacts things. And as Dr. Flynn talked about, deactivation protocols. I think every person here that does AUS devices, if we could have that patient learn how to deactivate their device at night, I think all of our outcomes would be better, period. So the 5160, this was published earlier this year. We looked at 90 patients with a 5160 that we placed all high-risk patients, all at least one urethral risk factor, some with multiple. And we looked at, after a median follow-up of 46.6 months, only 4 erosions and 4 infections. So if you compare this to the global literature of high-risk patients, this is very low. And then we just separated patients with strictly radiation. We placed, and in those patients that had a 5160, we only had 1 patient progress to an idiopathic erosion event. So beyond using a low-pressure balloon, can we also consider just doing delayed activation? So rather than just doing a one-size-fits-all activation schedule, 6 weeks for everybody, well, maybe we should space out the higher-risk patient. So we looked at 554 patients from our cohort, and we looked at these first-time patients, and we looked at their, and we separated patients between radiation and non-radiated patients. Radiated patients activated at 10 weeks, non-radiated at 6 weeks. And we found that overall, patients with radiation were older. They had, in general, they had larger size cuffs, and they also had a higher chance of having a 5160 pressure regulating balloon. So what were our results? So the table on the right side shows the indication for the first revision surgery. So the first is only in 4.7% did a patient actually present with an erosion as that first surgery. So overall rates of erosion, infection, mechanical failure were low. Now, biggest disclaimer, and for those that know the USC way, is that we love adjusting patients. So 5160 will bring them up to a 6170. So we talk about the adjustable nature of this AUS device, which attributes or accounts for that high rates of continence adjustment. But when we looked at overall erosion rates, that went up to about 7%. So, and there was absolutely no difference between a radiation and a non-radiation. So maybe we are actually making radiation a non-risk factor by being conservative with what we do. So takeaways, well, we also found that older age was really the strongest predictor of erosion. So that may be just because of suboptimal use or just increasing frailty. So when to give up? So again, 3 opportunities for an AUS. Maybe we should be kind of bringing that down a little bit more. And then we should be talking about other options like we talked about earlier. So in conclusion, the AUS is a great device, but there can be devastating complications such as an erosion. The goal should be prevention. There are many ways to manage erosion, but once you start developing erosions repeatedly, you should progress to the diversion, adjustable balloons, or just doing a simple suprapubic catheter with a urethral ligation. Thank you.